Hello, everyone. Einstein's Eyes, our YouTube channel. I'm Carl Rosen, oculoplastics, neuro-ophthalmology in Anchorage, Alaska, for many years. In fact, 30 years to be exact. My partner in crime.
Jon and Carl, nice to see everyone. So my practice is in northern New Jersey. I grew up in New York, like Carl, but I decided to stay in the tri-state area. And Carl and I started this YouTube channel, named it Einstein Eyes because of that's what we both trained together. And we're really excited today, as Carl will tell you, to have representatives from Einstein. So take it away, Carl.
Right. Thank you, Jon. So Jon and I were version 1.0. We were at Einstein back in the 90s, 90 to 93. And so today you're going to see and hear the newer upgraded version.
Yeah.
And we have a professor, Dr. Shrivastava, and Bryan Zarrin. Bryan is an ophthalmology resident representing Albert Einstein Montefiore, Department of Ophthalmology, completing his residency. But I'm going to let both introduce themselves, and we look forward to their story, and real excited to hear about it. So go ahead.
Yeah, so we after you introduce, we want to hear about the day of the life, like basically what it's like to be a resident. So take it away.
Absolutely. If I may go first, thank you for the introduction, and great to see everybody and the opportunity to speak. So my name is Anurag Shrivastava. I'm a glaucoma specialist in Montefiore. I trained at Montefiore myself. Shortly after, maybe I'm version 1.5, version 2.0. But I did my fellowship training in glaucoma out west, rejoined the faculty about a little over 15 years ago at Montefiore. And during that time, got very much interested in medical education. And became the associate director, then the program director, and in more recent years have taken on roles in our larger GME office, looking at all the residencies in Montefiore, and also have a title in the dean's office over at Einstein. So work with our medical students who rotate through all of our clinical sites. But my heart and soul is ophthalmology. I just came from the ophthalmology clinic. This is sort of where I still practice and teach primarily. In our years at Einstein and Montefiore, we've gone through so many changes. Our current chairman, Roy Chuck, took over shortly after I rejoined. So it's about 13 years ago. And it's just been a magnificent force and has brought such vitality to the department and expanded many of the offerings that we have. And in that time, we have a separate episode about the wet lab. That was a project that I had the opportunity to work on. And lots of other really interesting and cool initiatives that we've been doing in the department. But what I'm really excited about today, I think, is to introduce Bryan Zarrin, who is someone I've known his entire professional education career as an Einstein student. And we were so fortunate to recruit him to stay with us, and he's soon to graduate. So Bryan, I think your perspective would be great as a recent person, and I'm happy to add to your commentary as well. So I'll pause and turn it to Bryan. Please introduce yourself, and then we'll jump right in.
Thank you very much, Dr. Shrivastava, for the introduction and the very kind words. And thank you, Jon and Carl, for inviting us to join. I'm very happy to be here. My name is Bryan. I'm a PGY4 ophthalmology resident at Monty and Einstein. I am a New York born and raised in Long Island. I grew up in Nassau County. I went to NYU for undergrad. I was an economics major, and then I went to Einstein for medical school. I was there from 2016 to 2020. And while I was there, pretty early on, I was interested in ophthalmology. So I reached out to the ophthalmology department at Monty. I met Dr. Mian, one of the retina specialists there, and we worked on a project together over the summer. And I was able to rotate through the department there multiple times as a first year over the summer, as a third year during my clerkships on surgery, and then, of course, as a fourth year student doing an acting internship for a month. And I really felt like I got to know the department well. And I was really honored and blessed to be able to match there and stay to do my training there. And it's very full circle to do this episode now in May, which is about a little over a month from graduation. And it's very exciting. And I'm going to be doing a one-year cornea fellowship next year, starting in July, at UCLA, and with plans to move back to New York after that. So we'll see what happens after I graduate. So that's kind of a little bit about my background. And thank you guys for having me.
Sure, sure. Brian, that's great. So let's just start with the introduction to ophthalmology. So what inspired you to choose ophthalmology? I know you just mentioned you did a research project with a retina specialist, but was there something deeper? Was there something more meaningful? Did it start, in high school and college, or was it medical school?
No, so it was well before medical school, actually. And at this point, I feel like because I've written about it in multiple personal statements, it's a little bit more of a polished answer. But it started really in middle school because my dad has keratoconus. And growing up, I used to accompany him to his appointments, really at the optometrist at SUNY Optometry, where he was getting fitted for piggyback IOLs at that time. And just being in the clinic with him and seeing how they operated, the machines, the technology, the different testing, and kind of how clean and precise and focused their exams were, that really got me interested in vision. And as I got older, I started to learn the differences between, optometry and ophthalmology, and I was really more drawn to doing both, clinical as well as surgical approaches. So I wanted to go to medical school primarily to pursue ophthalmology, honestly, unless something really swayed me. And while I was an undergrad, while I was at NYU, I had the opportunity to shadow a anterior segment surgeon in the city. So he actually did a lot of LASIK and refractive surgery, which I found really interesting. And that kind of got me even more interested in cornea, having seen my dad's keratoconus, having seen refractive surgery, having seen cataract surgery. So it really, really pushed me to pursue that in medical school. And that's why early on I knew I should pursue a research project. I didn't end up applying to retina, but just to kind of get a sense of what the field is like. And I think that every step of my training, I kind of got more and more exposed to ophthalmology and realized like this is where I want to be.
So can you speak to Monty's program regarding cornea? Did that reinforce it? Did that sway you from retina, from glaucoma, from peds, from oculoplastics, from neuro? When John and I were there, I don't want to sound like, ancient history here, but, back in the
It was
Stone
a
Age.
long time ago.
Right. We used to use a Bunsen burner. No. So
Exactly.
back in the old days, neuro-ophthalmology was really the strength of Einstein. We had Ron Bird, Tom Slamovitz, and, our journal clubs, a lot of our, the morning teaching rounds was focused around ophthalmology, localization of a lesion, how it affected the pathways. Is that currently the state of things?
Well, to answer the first part of your question, yes, neuro-ophthalmology has always been a very strong and consistent part of our training ever since my intern year. We're now an integrated program. So our PGY 1 year, which I know historically was done separately from the ophthalmology 3 years, you would do a year in prelim internal medicine somewhere else. We're now integrated. So as of 2019, I believe, we started doing 3 months of ophthalmology during our intern year. We would be off of the medical floors. We would rotate through ophthalmology prior even starting PGY2. So even in that time, you get exposed to neuro-op clinic. We have a neuro-ophthalmology clinic every Wednesday. Originally was every Wednesday with Dr. Zhang, who see probably 40 patients a day. And we would see everything from IIH to tumors to optic neuritis to diplopia, strabismus, everything, starting as a first year. And so you got really adept and comfortable in those exams. And it really reinforced it as a second year when you're doing consults in the Moses consult rotation. It's very neuro-ophthalmology heavy. There's a lot of interdisciplinary management with neurology and infectious diseases. So we're very comfortable with it because of how much we're exposed to it. And now we actually have recruited a new neuro-ophthalmologist, Dr. Verma, because Dr. Zhang actually moved to China to be closer to his family. So we have 2 days a week clinic. Monday and Wednesday is a neuro-ophthalmology clinic in the triage walking clinic. And then Tuesdays and Thursdays, we have Dr. Jeffrey Basson, who also helps see neuro-ophthalmology triage patients where he'll staff from his own clinic. So it's very strong, neuro-ophthalmology. In terms of cornea, we see a lot of pathology every single day. Corneal ulcers, new ones that we're following up, we're culturing them, we're taking them to the OR for transplants after they've kind of settled. We're putting on procaras. We're doing tectonic grafts. A lot of infectious keratitis, and also great exposure to keratoconus and cross-linking. We have a clinic in Hartsdale that we do cross-linking about once a month, where the first-year resident goes, and we also get to see some refractive surgery where they're both PRK as well as LASIK.
I just
Fantastic.
want to add to Brian's answer just a couple of points, and that was very comprehensive and went over everything. We're a department that is now quite heavily vested in lots of different fields. We have we're soon to have 6 glaucoma specialists,
Wow.
5 cornea specialists, multiple neuro-ophthalmologists again now. Retina we have 5, so it's a pretty deep bench, if you will, for all the subspecialties, which is really great because the residents get an opportunity to see how all of us kind of operate and do different things and get a sense of the variety of treatment patterns. Despite all of us having a preferred practice pattern from the academy, there's obviously things that we all do differently based on the patient sitting in front of us. So one of the things I think that's really a high point of our program is that variability, that diversity in thought, and everyone's trained in different places and done different things, and so we all kind of bring our own flair to it. And we also have a very, very large neurosurgery department at Montefiore, and so with that comes a really, really high volume of neuro-ophthalmology patients specifically that require pre and post testing for tumor removals or resections and other things of the like. So, I think we're really clinically in a very unique place right now. And hearing the stories from version 1.0, it sounds like we're maintaining that tradition, and hopefully we'll build on it.
That's right. Yeah. John, what was your experience with cornea back at Monty?
So, I mean, I think it was great. I mean, we had Marty Mayers, who had a busy kind of meat and potatoes practice, I would call it. I mean, a lot of high volume. And we got to work with him, and the clinic was incredibly busy. Like, I was thinking when you mentioned the ulcers, I remember mixing the antibiotics by myself. I'm sure you guys do that all the time, right? But we used to do fortified antibiotics in the back room. We used to do a patient came in with temporal sided pain. We did our own temporal artery biopsies. We did our own sed rates. We spun it ourselves. So this was the old days. I mean,
I remember that, John. I remember that.
But in terms of cornea, then we had a really great addition when Peter Hirsch joined us. And Peter Hirsch is a brilliant guy who was really state of the art, and he was Harvard trained. And when he came in, it was just awesome. So we really had 2 kind of different vibe cornea people. But I mean, I remember, I think as a third year, I think I must have done, I think I did 8 or 9 corneal transplants in a year. I mean, that was unheard of compared to the other people I knew. There were in other programs, Manhattan Eye or New York Eye, they did a couple of transplants. I mean, this wasn't obviously before DSEC and DMEC. So when I came into my cornea fellowship, my attendings were very impressed. I mean, they felt like, I was way ahead of what they had seen in fellows before. And it wasn't because I was necessarily better. It's because I had a great training and just such a great experience.
So, yeah, we used to have a journal, and we had to have it stamped by an attending to make sure that we were competent and that our skill set was really thorough and valid. Brian, do you have that now? Do they have that implemented?
So yeah, it's not a physical journal, but as a first-year resident, we have a few things like a checklist that's been created that need to be signed off by a senior resident, having been supervised doing them at least twice before they can do them on their own. For example, corneal cultures. So a junior resident needs to do it under the supervision of a senior resident twice before they can do them on their own. Similarly, examining a NICU baby or a premature baby, removing a corneal foreign body, and a few other things on that list. So we do have one that I think is actively growing and monitored by our program director, Dr. Rosenberg, to make sure they're meeting minimum competency before kind of doing things on their own. And similarly, when we meet with the department twice a year, midway through the year, we have a mid-year feedback, as well as at the end of every year, we are required to get 2 faculty evaluations. And the faculty evaluations are mixed between clinical competency and surgical competency. So they are trying to make sure that as we progress from year to year, that we're kind of reaching those milestones.
Yeah.
That's good.
So,
That's really good.
I mean, it's interesting. We have 4 previous ophthalmology residents at Monty, all in
Yeah.
one place.
That's cool.
And the timeline is quite spread out. So, and again, John and I represent 1.0, Anurag 1.5, Bryan's 2.0. But back when we were there, John, we had to do, I believe it was 100 cataracts, right? Wasn't that right?
That sounds high, actually. There were definitely people that did less than that.
But I mean, Anurag, when you were there at Monty, did
I
you
know,
have
I
that?
know they told me that I had to stop. That was a controversy.
I mean, is there a number that
That was a
you have
tad,
to
it was
hit?
a tad aggressive.
I
But,
can speak to it.
yeah. I
So-
mean, so they actually said to me, I have to start handing cases to the junior residents, but there was a specific time that was supposed to happen. I don't remember if it was April or May or whatever it was. And they wanted me to start like 2 months early because I was way ahead in my numbers. And I said, I worked hard for this. Like it became a real big thing. And I won. I mean, I basically said, listen, I'm here to train. And I've been very organized and I've been pursuing patients and calling them and saying, are you ready for and they gave in and they said, keep operating. But yes, how are you guys doing that?
Surgical numbers are always a thing, right?
Yeah.
And when cases are sparse, it's even more of a thing. I'll just give you some background from just the nation perspective, what the ACGME requires. So the number has been 86 for many years, the number of cataracts that a resident should do. And it's actually not a specific resident, it's not a cutoff. It's the average number that a residency program gives per resident in the course of. So if somebody did 60 and someone did, 100 and you got to 80, you'd be under. But if you had slightly more, you'd be okay. But obviously that's not how this should work. And 86 actually comes from the 20th percentile of the number of cases done annually when they audited it decades ago. And it has no relevance to learning curves and changes in technique and all the things that have happened in our years, right? From 1.0 to
we
2.
used to do 4 cases in a day. Like 4 or 5 cases was like, I mean, now so my understanding is the numbers are much higher now, correct? I mean,
Yeah, there can be. It depends on the operating room and the site, but they're certainly higher than 4 at a lot of our sites.
Right.
And some of our attendings, even in an academic place, are doing dozens a day.
Right.
And the residents are involved with many of those. So it's the numbers are always tricky because not everybody progresses at the same rate. But the way we've managed it over the years is, we monitor with ACGME case logs how many resident cases are being done by each resident, and they're looked at in multiple points during the year to make sure people are logging, doing, and making sure they're above minimums for sure, and hopefully much more. Over the last, I'm going to say 5 to 7 years, our surgical numbers have gone well beyond anywhere near the minimums. And so we haven't had to deal with that moment of like, oh, you have 74 and I have 90. How do we get to 86? We've thankfully been well over that and certainly on the higher end of programs in New York City for sure. So we're in a pretty good place in that regard, but it's a lot of logistics and work to get that done. And John, as you're saying, you got to follow those patients. You got to make sure they show up to their pre-op appointment and get this.
Yeah, it's a lot of work.
But
Yeah,
Bryan, I'll
that's
let
not
you
work.
as the one doing this in real time. Do you
Yeah.
have any additions to that or?
Yeah.
It pretty much is the same as what you described. 86 is still the cutoff, but to give some perspective, I know last year's class finished between, I think, a range of like 150 and 200 cataracts.
Yeah.
And we're, I think, on pace to be very close to that in the range, at least for sure. And it's true. The cataract booking is very exciting because it's really the first chance we get to kind of have complete ownership over a patient from start to finish, examine the patient, consent the patient, and then also make sure that you're following up with them. So cancellations happen all the time for various reasons. And I'm currently at Jacobi where there's a bit more involved in order to get a patient into the OR. Basically, every patient needs a pre-op medical assessment. Every patient needs labs drawn. Every patient needs an EKG done prior. So I'm doing a lot of, I have a spreadsheet, I have an Excel spreadsheet, and basically every day I call at least one or two patients, if not more, to remind them when their pre-op medical
Right.
appointment is, to
That's,
make sure they have a ride, to make sure that they, have an escort to the day of the surgery. And then I've actually called nursing homes a couple of times to ensure they have transportation set up. I've called a dialysis clinic to alter their dialysis days to make sure they can get it the day before their OR day. It's a lot of work. It's more involved at Jacobi. At Montefiore, it's a little more streamlined, and I think the patient population's a little different. They're a little less complicated medically, and so we're able to get most patients in and out of the operating room without any issues. But having seen both sides, it's good to know kind of what goes in the background and behind the scenes. So we'll be prepared for anything.
well, one thing you just brought up that reminded me of something. I really felt like the strongest part of the program was the fact that we had these private attendings that were running businesses. They were, they had a focus that was a little different than the academic people, but we got to experience them more at Einstein back then and a little bit of Monty. But then, and we had to be a little bit more subservient in those hospitals where you had more private patients, a little more demanding. And then in Jacobi, and back then we had North Central Bronx, where we were the show, and we did a lot more volume there. So I love the idea that we had the balance between both. I mean, do you feel like you're getting that?
Sorry, I was just turning the mic on. Yeah, no, you hit the nail on the head. Very much. It's two different flavors. At Montefiore, we have a resident run clinic. So we do have kind of ownership over patients that we've been seeing, either who originally came through the emergency room or through the inpatient service, or just walked in with an eye complaint off the street. We saw them, and then we set follow up for them to come back to see one of us. So we have that, and a different attending supervises it. But right next door, we rotate through private attending, and we're seeing the attending's private patients, whether that be retina, glaucoma, plastics, neuro, cornea, and then we discuss it with the attending, and we see their plan, we see how they operate, we see different flavors and different practice styles, the way Dr. Shrivastava mentioned. But then at Jacobi, we are the, like you said, we're the show. We're calling the shots. We're supervising everything with an attending, but there's a lot more ownership. It's our patient, because the attendings at Jacobi are all there per diem. They're all there once a day, or sorry, once a week. They have a private practice.
Right.
They work in 4 days a week, and then one day out of the week they come to kind of work with the residents. So we are the continuity of care there, whereas they're just supervising. So it's nice to get both of them.
No, I think it's so. One thing I will tell you, so I've been in practice 30 years now. I've hired now actually three ophthalmologists that have joined me over those years. That's one of the things I looked for, because I know that some of the residencies don't have that. And so if you got anyone watching this video out there, if you're in med school deciding where you want to go, obviously Einstein, Montefiore is not the only place that has that balance, but you should look for a place, to me, that has that balance, where you're going to learn from people and be dealing with patients that are private, because they do have higher demands. You want to learn that skill set, but you also want to be independent. So if you're doing too much of one or too much of the other, I think it's a problem.
Yeah.
Yeah.
Yeah, John, I mean, having that business sense from the private community is really important, because, and I think medical schools and residencies, because I'm running a business. I mean, I have 50 people. We have a multi-specialty practice. We have the largest practice in Alaska, and that requires that I know a little bit about finance and a balance sheet. And I mean, I have to negotiate contracts. I have to know a little bit about law. I mean, all these things are super important. And if you don't, you'll get steamrolled, and sometimes, things can get really sour. But so that's a very important point, John.
That's good stuff. It sounds like you have a great experience. I mean, I think when we were there, I think I might have done 140 or 150, and I definitely was the most in my year. But there were people that definitely did in the 80s that I remember.
I think I did 105. Yeah. But I did a lot of trauma, and I worked with oral surgery. I was the trauma guy.
Yeah.
I mean, Honig was interested in also. John Honig, he does orbit oculoplastics at UCLA. But I jumped in with both feet with oral surgery, doing tripods and orbits and things like that. And Simeon Lauer helped me as well with oculoplastics. But Bryan, getting back to you, so can you run us through the resources that are available to you, and then a day in the life. All right, so I mean the title of the YouTube topic today, but really perhaps you could summarize it from, Sunday to Sunday, the educational parts, the clinic parts, the surgical parts, just to give, again, a prospective medical student a sense of what you're going to get at Monty, the rich availability of possibilities.
Sure. In terms of resources, I mean, we have plenty. In Monty, we have a full lane, a triage lane that's the resident run clinic. We have 4 rooms that are equipped with slit lamps, and they're fully equipped with all of the medications. And the 4th room actually has a video indirect as well as a TV screen connected to the slit lamp that you can actually teach residents and medical students what you're seeing. We have a very beautiful new wet lab that Dr. Shrivastava mentioned earlier, that is open 24/7 for us. I don't know exactly how many microscopes are in there, but there's plenty, enough for more than one for each resident. We have wet labs there throughout the year. We've had phaco wet labs. We've had reps from different companies come from Johnson & Johnson and Alcon, you name it. Show us MIGs, show us phaco, show us the different IOLs. We have access to all of the reps for cases. If we want to do multifocal lenses or toric lenses, I just did an iStent Infinite earlier this week. They just got on contract at Health Hospitals, so they said this was like the first one that a resident did there, which was really nice. And at Jacobi as well, we have a very busy clinic there with attendings from every subspecialty who are always available via text or in person to go over cases. And in terms of a day in the life or a week in the life, so Monday morning, we do what's called weekend sign out. So all of the consults that were seen over the weekend are compiled onto a spreadsheet. And then the senior resident on backup call that weekend selects a few challenging or interesting cases to present to the department Monday morning. We all meet in the Centennial Library, and the attendings that are available that morning join both in person and also virtually via Zoom. So the residents who are at Monty that day, it's scheduled to be in Monty Clinic, come in person, and the residents who are at Jacobi log in via Zoom at Jacobi. And we go through
back and forth.
challenging cases. Yeah. So we used to drive back and forth. When I was a medical student, even that was still the case. When I was rotating, so I would show up in the morning, and then the residents would drive to Jacobi right afterwards. But ever since COVID and being virtual, we've developed this hybrid system that I think works really well to kind of save people that time in the morning so they can comfortably start clinic. So we'll go over Monday morning sign out. Usually Dr. Shrivastava is pretty much always there. Dr. Rosenberg, our program director, is there. Dr. Chuck is there. Dr. Bassin is usually online as well with a few different mixtures of retina and glaucoma kind of here and there. So it's nice because you got a very interdisciplinary, multidisciplinary team ready to answer questions about these patients that are challenging, which are why they're being brought up. And that goes till about 8:30, and then we start clinic. We go through a full day of clinic from about 8:30 to 5. Usually we're able to work efficiently enough where we're given a nice lunch break. Typically we can even have lunch together. The residents, if it's nice out, we can go outside and eat in the Montefiore courtyard by the fountain. And when it's a little colder out, we can go to the staff lounge, or even in the wet lab sometimes we'll go to. There's a separate room where there's a conference room and a table, and we can kind of eat together there, which is very nice. And so for me, Mondays would be clinic. Tuesdays are my OR day. So I operate at North Central Bronx right now because I'm on the Jacobi rotation. So we start at 7:30. The first case this past week was actually really great. We did 8 cases there. And the turnover was great, and we were able to finish by about 3:30, which was nice. And then Wednesday, Thursday, Friday is clinic. And I'm at Jacobi currently, so you can either be at the Montefiore Clinic or the Jacobi Clinic. And for me, Wednesday is a clinic day that's a mixture of retina and general. And today, Thursday, was a cornea day. And I had a case in the morning, so I did one cataract in the morning with Dr. Polo, one of the cornea attending, who used to be a resident at Monty also. Did his fellowship at Manhattan Eye and Ear, and now he's back as a cornea attending one day a week at Jacobi. So I did a case in the morning, and then I had a full day of cornea clinic with him and mixed with general. And tomorrow we have glaucoma clinic. So interspersed through that, sorry, I forgot, we have lectures in the morning. So between 7:30 and 8:30, for example, this morning we had a pediatric strabismus lecture, or even adult pediatric strabismus lecture, because that's our current focus. Our academic calendar is currently doing pediatrics. So we'll usually have a lecture from 7:30 to 8:30 before clinic starts. And same thing, whoever is in Montefiore attends on in person, and whoever's at Jacobi attends via Zoom. And it's been really nice. You get a mixture in one day. You get you do a surgery, you get a lecture, you see a bunch of patients, you can do procedures. We do a lot of YAGs and LPIs. Sometimes we're going back and forth between the operating room and clinic, specifically at Jacobi. You can see a few patients, go do a cataract, come back, see a few more, and then by the time they turn over the room, you can head back. So it's a busy day. There's a lot of variety. It's a high volume, and we always manage to kind of get done around the right time.
Good job. Good job. So I was wondering, how about research or paper writing opportunities or going to ARVO? What's available?
There's a lot available. So we're given multiple designated academic times throughout the year for residents to have half a day off dedicated to doing whatever they need for their research projects. And you get multiple of them throughout the year that the chief residents help schedule and make sure it's kind of even between each resident. We are all getting ready actually to present our research projects at our annual Henkind Day, which is going to be next Friday. So the second and third year residents present original research projects, and the first year residents present case presentations. And the entire department goes. The clinics are closed that day, and it's a very nice day. It's at Wave Hill, and we look forward to it every year. It's a very fun event. And in terms of paper writing, we have a lot of attendings who are very productive and publish multiple papers throughout the year with residents and medical students from Einstein. And you're encouraged to publish, because if you get a first author publication, you're entitled to an extra vacation day. So there's some incentive to publish as well per paper.
Holy cow.
We have and we have funding available to us. There's funding available to us to attend conferences. So two of the residents recently were able to present some case presentations at the NISOS, the New York State Ophthalmology Society event a few weeks ago. One of our first year residents, Kemi, he was just in DC for mid-year forum. And every year, the senior residents all get full time off from clinic to go to AAO. This past year it was in San Francisco, so my whole class was there. Dr. Shrivastava was there. We have an alumni event there, which is very nice. And all the other conferences are available to you if you want to go to ARVO, if you want to go to Nanos, ASOPers. So it's really up to you. You can make it happen. And there's coverage, and there's funding, and there's time available.
That's great news. So listen, that was fantastic, Bryan and Anurag. Thank you so much. But John's got to head off.
I want to go back and do another residency. It sounds so awesome.
Right. Particularly now that Einstein has all that money. I'm gonna publish like crazy.
Yeah. Very nice to meet you guys and see you. I really, it was very informative, really great stuff.
Yeah.
And I will say, as a final, sorry to interrupt, as a final thing, we also do have, and I think one of my favorite parts about the program is we have some funding to do we call family dinners. For our class, we get about like $50 or $60 to do like a PGY4 dinner once a month, or a PGY3 dinner. Their gets it. And a few, we just had a nice Bronx Brewery happy hour. So we try and do those things as well, and kind of build morale and camaraderie, and it's very well attended. So
that's fantastic. Great. John, anything else?
Yeah, that was wonderful. Have a wonderful night, guys. Really appreciate your time after a long day. Go eat some dinner.
Right. Yeah. Thank you so much, Bryan. All the best success to you at UCLA for your corneas fellowship. And
thank you.
Anurag, thank you again for being here. You're running a great program. Really
impressive.
Very impressive. And we'll be in touch. And perhaps, Bryan, you'll tell us about your fellowship.
Yeah,
in a year or so.
Yeah, maybe you want to come.
We'll do
Maybe you want to work in New Jersey. We're 20 minutes from the Lincoln Tunnel. So keep us in mind when you're looking for.
All my options are open right now. So we'll.
All right, good. All right, good.
Alaska too.
We'll see.
Yeah, so John had to run. John's a councilman and he has some an obligation to go to. But Brian, was there anything else you wanted to say to finish up?
For anyone listening who's interested in our program, I also help run the Monty Ophthalmology Instagram page. It's called Monty Opto, and I try to really post a lot of what it really feels like to go to the program. I think we do a pretty good job, and you should check that out as well. And it's very bittersweet to leave. I love the program a lot. I think the culture at Monty is excellent. It's why so many people have graduated from here and then came back to be faculty here. It says a lot about the program, and I'm really grateful to have trained here. And I'm gonna miss everyone when I go. So it's a good place, and you should try to check it out.
Absolutely. I second that. And, like I said, I'm version 1.0, and we've managed to create a YouTube channel based on my experience and John's experience. And, John and I are friends from way back when.
Yeah,
And right.
I'll echo these sentiments, and it's an honor to have students like Brian and now residents and soon to be ophthalmologists to see them go through the entire spectrum. It's really, as a faculty person who's been here for a little while and seen some cycles of this, it's just really some of the best things I think that we can do with our time is just to give back and to create a better program, and we continually strive to do that. And Dr. Rosenberg, our program director now, and Dr. Chuck and other leadership. I've been given some credit during this, and I appreciate that. But this is such a team effort. There's so many people who are involved with creating, what we've done here, which is really like it's a small family, but it's a huge family at the same time.
Right.
And we create that in this large institution, a really, a feeling of camaraderie that, I think is largely unparalleled.
Wow.
Which is great. So
Fantastic. Well, thank you so much, guys. And please check out, like the channel, subscribe, and we will see you on the next one.
Thanks, Carl. All the best.
Thank you.